All right, thanks. Lucy Pam Danyang from Nigeria says, great session, and we haven't even started. We're 1 minute and 37 seconds away from starting this we're trying something new with Insights Live. If you've participated before, we do this after Teach to Reach, which is this massive peer learning event. Over 17,000 health professionals from more than 80 countries participated in the October 2023 edition. Insights Live is about asking you a simple question. What have you done with what you learned? How are you applying it? How are you using it, for example, to identify and reach zero-dose children? And we've done a number of sessions like that. Today's going to be a bit different. In just about a minute, we'll be engaging in a new kind of dialogue with Orin Levine, one of the guides on the side for Teach to Reach 9, and Teach to Reach 9 contributors who shared experiences before Teach to Reach back in October, and that's led to more questions and insights that we're going to explore today. So that's the plan. I hope you will enjoy this session, and I hope that many of you will be sharing your comments and reactions and questions as you hear the session go on. All right, and via YouTube, we have Mary Goretti Akini, who says, hi, everyone. Happy New Year. I'm experiencing the same. All right, 10 minutes to go. 10 seconds, not minutes. Okay, here we go. Once again, we're kicking off. This is our first live stream in 2024 with, of course, Charlotte Mbu. Charlotte, how are you doing in 2024?
Hi, Reda. Hi, everyone. I'm doing great, and it's so great to reconnect in 2024 under the Teach to Reach banner for this very special Insights Live. Thanks, Reda.
Thanks. And indeed, if you have poor connectivity, we do have a solution for you. If you're trying to listen to the YouTube stream, but it's not working, or wherever you may be listening in, you can go to the podcast. Just type www.learning.foundation/podcast, and you can get this session as well as much other great content that can help you in your daily work of immunization. You can plug into this global community using audio only if that is a need that you have. We already have a lively discussion starting in our Zoom studio. We have Teach to Reach 9 contributors with us, and you'll be hearing from a number of them on especially two topics, zero dose and measles vaccination. But with us, as I said in my introduction, Orin Levine, who was one of our guides on the side at Teach to Reach 9. So logically, we're going to start with the first question to him. What exactly is a guide on the side? How is it different from the sage on the stage?
Thanks, Reda. Super excited to be with you all today. I guess I think about a sage on the stage as somebody who's sort of wise, but a little bit further from you. There's something about being on the stage that separates you. Whereas I think of a guide on the side as somebody who's alongside you, someone who's helping you on your journey, it's more intimate in a way than a sage on the stage. I guess that's the way I think about it.
All right, sounds great. Next question for you is the following. This is your LinkedIn profile picture. I can't help but ask. I saw this and I said, okay, we got to ask Orin, when and where is this? Why is he smiling so much?
Okay, well, it's definitely a few years ago because there's no beard. That's the first thing I can tell you. And it's either 2018 or 2019 at the World Health Assembly. I think there's a couple of things about this photo that probably are indicative of the way I approach things. One is I think I start with a commitment to equality. It's just sort of an important core value for me. Two, I like to aim high for big, hairy, ambitious kind of goals. And three, I'm pretty optimistic. I think there's a lot of things that can get you down in the world right now, but I still think that the arc of the universe bends towards justice, even if it does it slowly. And I think that's why I'm smiling.
All right. Thank you. Now we have some comments online, and just to begin the frame, what we're going to be discussing around Teach to Reach 9, 1,817 experiences were shared. We're going to be looking at the ones in English for this session. And before I go any further, I just want to say hello back to some of the folks online who've been sending greetings. I'm only going to be able to share with a few of them. So Jamal Liban, Mohammed Quresh Jamali from Ethiopia says it's difficult in Zoom. Glad you're able to follow via YouTube. And Stella Mamuti says something that I think in a way kind of sums up Teach to Reach. I thought I was the only one experiencing this challenge. And in this case, we're talking about immunization challenges, even as Teach to Reach is broadening to other challenges such as climate and health, non-communicable disease, and other areas. And then Faiza says, so good to be with you all. Please tell us where you're from, even if Faiza, I believe we know you, but just tell us where you're from, what you do, and feel free to share, ask your own questions and share your own comments as we progress. So 1,817 experiences. We shared the English language ones with Orin Levine. This was back in November, and this is what he wrote. You can see his message here. I got through slide 340, and then I had to wrap up and head to bed. That said, wow, incredible to read all of these experiences. I learned a ton. I have a bunch of slides that I'd love to follow up on. Orin, could we ask you to share one example of something very specific that surprised you, that you shared with your global colleagues, saying, here's something that you learned tangibly that others need to know?
Well, thanks, Retta. Yeah, I mean, I think generally one of the things that really struck me is a point you were making just a second ago, that so many of the examples from the field were similar, even though they came from different people across the field, different people in different places trying to solve some of the same problems, and sharing that experience with one another was kind of amazing. And I guess one of the ones that I think we'll talk a little bit about today was the experience that people were having in trying to kind of engage parents, caregivers, in understanding how they were responding when kids had adverse events following immunization. We know they occur. We also know that they occur in part because the vaccine is working to protect the kid. And so I was super interested to learn more about how they use that dialogue to kind of acknowledge a parent's legitimate experience with vaccines, but also address it in a way that made the parent continue to bring the child back, rather than simply choose to cease immunization because there was an adverse event. So that was one of the things I learned that people were experiencing, and I'm eager to learn more about how they're handling it.
Great, thanks, Orin. Now comes a bit of a challenge. This is a quote that we shared actually quite widely. Stories together with evidence can really influence and change the way people take action and solve problems. This is what you told us ahead of Teach to Reach 9. But is the implication that for you, stories don't qualify or count as legitimate evidence? What's your take on that question?
Well, if that's the way you took it, that's not the way that I meant it.
Okay.
I guess for me, like I work in an environment, I think, where a lot of people have this sort of very linear approach to thinking about problem solving, which is, I'll experiment, I'll collect evidence, I'll show people that, like, the evidence says X, so you should do X. And my experience is that evidence is necessary but not sufficient. That when it comes right down to it, there's an element of all of us, every one of us on this call today, who are, we're driven by stories, right? Mm-hmm. Stories compel us in ways that sometimes evidence doesn't. And I'll just give an example in a way that might sort of illustrate this. As folks on the call may or may not know, my last role, I was at the Bill and Melinda Gates Foundation, and I was leading the immunization primary healthcare work there. And I read a lot of stuff that Bill wrote, including Bill's book about climate change. I liked it. I learned a lot in it. It was full of data and evidence, but it didn't drive me as much to personally think about climate change and my own contributions as a different book that I read just recently. That book is called Ministry for the Future, and it is a fiction book. It's a fiction book grounded in sort of data, but it tells it as a story where people are central to the story, to the experience of climate change and the reactions to it. After reading that book, even though it had less, if you will, hard evidence than Bill's book, I sort of came back and said to my wife, like, oh my God, we really got to do more about climate change. So I think evidence and stories both have a place. I think evidence is not enough, and that stories together with evidence can really influence and change the way people take action and solve problems for the better.
Wonderful. Thank you, Orin. So we're going to dive right in. This is about Teach to Reach Connect, really a unique opportunity for health professionals from all over the world to meet, network, and learn. Just as a sneak preview, Teach to Reach 10 will be happening in June 2024 with a focus at the top of the masthead for Teach to Reach 10 will be the front line of climate change and health, in fact. Now, today we're going back, reflecting on Teach to Reach 9, 17,662 health professionals reached. And it's not about the connections of the Geneva Learning Foundation with you, it's about the connections you make with each other. Here, the social networking analysis shows the French and English language groups. Now, out of Teach to Reach comes experiences. 1,817 of them. I think these numbers actually went up in the final version, so this was back in October. It goes into the Knowledge to Action Hub, which is part of the Movement for Immunization Agenda 2030. It goes out into many different kinds of channels so that wherever you are, when you have a problem, a challenge you're trying to solve, you can tap into this global knowledge, global set of experiences. Now, to dive right in, at Teach to Reach 9, in partnership with UNICEF, we focused on identifying and reaching zero-dose children with vaccines in urban and peri-urban settings. We know that in the movement for IA 2030, 42% of you, almost half of you, work with the urban poor. And this is from a sample of 6,185 professionals who joined the movement on the 7th of March, 2022. So I'm going now to hand it over to Charlotte and to Rosemary Adejo, who will be our first contributor. Just lining up the slide. What we're going to do is the following. Charlotte is going to sum up Rosemary's story. Rosemary is with us in the room unless connectivity failed her. And then we'll, once we've understood the gist of it, we'll look at what questions and comments this elicited for Orin. We've got them in writing, and of course, we've got both of them in the room. Charlotte, over to you.
Thank you, Reda, and a warm welcome to you, Rosemary. So you shared with us about enhancing access to immunization through multi-care providers in Nigeria, talking about the collaboration with traditional birth attendants, medicine vendors, and other community-based structures to identify and reach zero-dose and under-immunized children in Nigeria. These community structures are encouraged to refer caregivers to facilities for vaccination services. So the questions that Orin had for you were, can you elaborate on how the partnership with patent medicine vendors is structured and its effectiveness? How did you engage with them, and what differences is this kind of partnership making as far as immunization is concerned? So over to you, Rosemary, and please do start by introducing yourself.
Hello, everyone. Hello. Can you confirm you can hear me?
Warm welcome.
Yes.
We hear you loud and clear.
All right, fine. My name is Rosemary Adejo Adaji. I reside in Abuja, Nigeria. I work for a non-governmental organization called Women Friendly Initiative. It's an organization committed to improving lives of women, girls, and children in Nigeria. So first and foremost, I want to say thank you very much for spotting out my contribution. Thank you, Dr. Orin. Thank you, Dr. Reda. Thank you, Charlotte, for inviting me to talk to us this afternoon. For talking about partnership with patent medicine vendors, so the patent proprietary medicine vendors are non-traditional health providers who sell pharmaceutical products on retail basis, though without training in pharmacy. So they are popularly called chemists in chemist shops in Nigeria. And almost on every street you go to in Nigeria, you tend to see a one patent medicine vendor. So they are always the first point of care for most low income Nigerians. As a matter of fact, it's only when issues get complicated that people start looking for the four walls of university, of an hospital. So most times people want the first point of call is always the patent medicine vendors. So this is what the partnership we carried out. Actually, my organization 4 years ago was working on a project that was aimed at reducing maternal mortality through tax shifting. So and then we identified these patent medicine vendors and other multi-cater providers, we have traditional birth attendants, and then we have depot holders. We call them depot holders. So they are artisans like tailors. So basically to help us to generate demand for maternal services in facilities. So after I joined Teach to Reach, and then I started thinking of one innovative way to actually use the existing structures, use what I'm doing to actually improve immunization coverage to ensure that issues around zero dose children is a thing of the past. And that was why when the PPMV structure came to my head. So I now decided to engage them. So I'm currently working with 25 patent medicine vendors. And then there's a model, using a model called a cluster model. So I'm working in 5 slums. So in each of the slums where we work, we have 5 patent medicine vendors. We have 5 primary healthcare facilities that we have identified. We have community mobilizers, and then we also have the private clinicians. So one of the things we did was that we needed to see how we could penetrate these people, talk to them about immunization, talk to them, because the truth is, most times women, when they want to take delivery, they come to me, these patent medicine vendors, because some of them are also traditional birth attendants. And then they take their delivery because they are affordable, they are cheap. And most times after the whole delivery, they go back home. Nobody talks about immunization anymore. So we said, okay, how do we increase this access to immunization services? So that was when I started talking to these patent medicine vendors, of course, through their association called National Proprietary Patent Medicine Vendors Association. So, and then what they do for us, basically, when these women come to their center to buy drugs, even from the stage of pregnancy, so they started identifying them already. And the next thing they do is they link them up to the community mobilizers, because we have a review meeting which we usually organize quarterly for this cadre of persons I call. So whenever a woman in question has put to bed, for example, and then the next point of call is to start seeing how they could reach out to them to go for their immunization services. And some of these slums I'm talking about are also hard to reach areas. So what they do, they also contact the primary healthcare officials during their routine immunization with this contact, and then asking them to go to their various locations to immunize their children. So if it is in the private facilities, so in the private facilities, for those of them that can afford immunization services, because most times people pay a token to access these immunization services. So the private,
Rosemary?
the private.
Rosemary, Yeah, I'm going to interrupt you. One, for the sake of time, I understand,
Okay.
and again, I realize you're sharing a lot of experience in a very short time. But I'm interrupting you for two reasons. One is because there's a specific question from your colleague, fellow scholar and Teach to Reach participant Boma Otobo. Says, "Well done on your presentation on partnership. How did you go about selecting the patent medicine vendors, and how do you determine when to discontinue with them? What is the determinant of effectiveness?" If you could give a quick reply to this question, and then we'll go to Orin, because he read your story, your experience in the middle of the night, and it left him with the questions that we shared with you. So we're going to go back to him and ask him, well, does he have further questions, reflections, comments? What would he like to say to you now that you are both in the room together at a reasonable time of the day? But first, could you answer Boma's question? How did you select the patent medicine vendors, and how do you know they're effective?
Okay, thank you very much for that question, Boma. So in terms of selection of the patent medicine vendors, so we usually do the selection through their association, NAPMED, so who gives us the approval to contact them. And then we now go around and then we check. Sometimes we look at the location of their the drugstore, and then we also have things like in terms of what kind of pharmaceutical products do they sell? So are they meeting? Will they be able to meet our needs? So those are some of the things that we usually consider. And then in terms of effectiveness, we usually have tools, monitoring and evaluation tools that we give to them to document services they provide to these clients when they come. So on a monthly basis, we'll go back to these facilities and then to see how many persons they have referred to the facility. And as I told you before, it's a model that we are working with. And then if they say they've referred 5 women to the facility, so what the next we'll do is that we contact the PAC in that particular location. We say, okay, this person, we have referral tools as well. So, and then some of these feedback copies and some of the tools we also receive back to check to see if there was a two-way referral, and then to also see if that client referred actually assessed the vaccines or the services that person was referred to. Boma, I hope I answered your question.
Thank you very much indeed, Rosemary Adejo-Adaji. So you're a public health specialist working for an NGO at the national level. You're based in Abuja. Now, Orin, you read really a paragraph from Rosemary. You've now heard it's a lot and it's a little, obviously, to describe. It's too little to describe the richness of experience, and you can hear Rosemary's commitment. But what did you hear in her responses to the questions you asked and beyond that?
Yeah. Thanks so much, Rosemary. I learned a lot from listening to you expand upon the model. I guess a couple of things that emerged from listening to you, and maybe one sort of final question suggestion at the end, which is I think what I learned in listening to you describe this was really how you systematically broke the cluster model down, how you selected the different chemists or PPMDs, the traditional birth attendants, and in the last reply, also a little bit how you track that progress by monitoring the referrals that are occurring through that. I think one of the things that drew me to your example was just the sort of observation I guess I've had that sometimes folks who aren't of the private sector can feel intimidated sometimes or distant from working with the private sector. And so I guess one of the things I would encourage you to think about, and maybe this is an area for growth for everybody, is just like, what advice would you give to others who are in a place where the private sector plays a role in healthcare, but they haven't engaged them? Have you learned something from reaching out and working with the private sector generally that might help somebody who's aware of their existence, but not really sure how to start that partnership or relationship?
Thank you. Orin Levine, our guide on the side for this Insights Live. We're going now to travel from Nigeria to India. and we're going to be learning from and with Dr. Isha Goyal. Teach to Reach 9 measles outbreaks were one very important theme. We had a set of what we call Teach to Reach questions. Dr. Isha Goyal was one of the Teach to Reach participants, one of the 17,662 Teach to Reach participants who took the time and care to share her experience. And while going through almost 1,000 compendium of almost 1,000 experiences, Orin Levine was struck by what she said about her experience. Charlotte is going to lead us through this story and through the dialogue.
Thank you, Reda, and welcome to you, Dr. Isha Goyal. So you shared that you noticed that measles outbreaks occurred in areas of known pockets of poor vaccination coverage as a result of hesitancy for a number of reasons, like fear of AFIs, myths about vaccination, the inability to go to vaccination session sites, and that most of those that were vaccinated were 90% from a Muslim community. So the question that Orin had to ask to you was, given the known pockets of under-immunization, what strategies can be implemented to ensure vaccination before the outbreaks occur? And Isha, please, can you start by introducing yourself, telling us who you are, where you work, what you do, before answering the question. Over to you.
Hello, everyone. I am Dr. Isha Goyal. I am based in Muzaffarnagar district of the largest state of our country, that is Uttar Pradesh. And I work as surveillance medical officer in World Health Organization. My basic things which I do are surveillance, and I look after immunization. And regarding the experience which I have shared regarding the measles vaccination, so the outbreaks where which I mentioned that they occur in already known pockets of poor vaccination, we've started from the baseline by doing a survey in such areas, that what are the reasons why the vaccination is poor in such areas. So some of the reasons, some of the strategies we are able to implement successfully, like if there is less number of sessions, because we generally conduct one outreach session for approximately 1,000 to 1,200 population. So we ensure that appropriate number of outreach sessions are conducted in those areas, so that there is no problem of going to a large distance to get their child vaccinated, because generally mothers take their child to get them vaccinated and they don't have any conveyance to go there, they have to go by walk only. So we arrange the sessions sufficiently so that there is no problem of transportation. Secondly, if there is field level workers are not present there, or mobilizers, we can say that they are not available in that community, we try that each of the area has one mobilizer attached in that area, so that they can tell the family that the vaccination of their child is due and they have to get their child vaccinated as per age. So they inform the family or mobilize the family, then only the mother take their child to get them vaccinated. Third is AFI apprehension, out of which the fever is the most important reason, which I mentioned that pentavalent is given at 6 weeks of age, and that is the first vaccination which is given in the field, because BCG is generally given during the institutional delivery. In the field, pentavalent is the first vaccine which is administered, and since it results in fever, so mother gets apprehended, because she is the only one who has to take care of the everything of household, the household chores, their family and their children also. So the mothers find it difficult to manage everything when their child gets sick. but still we are implementing the strategies like every vaccinator has to explain the mother that what vaccines she has given to the child and what side effects will occur because of such vaccines and what are the advantages of these vaccines, so that mother doesn't get apprehended by the fever and come back for the next dose also. And secondly, we distribute paracetamol syrup to each and every child who is instituted by pentavalent vaccine, so that they don't have to purchase or they don't have to do out of pocket expenditure to purchase the paracetamol or any other antipyretic drug to get the relief in fever. These two strategies we implement so that mother comes for the next dose also, because the measles containing vaccine is given at 9 months of age. If the child completes 3 doses of pentavalent vaccine, then only mother comes at 9 months of age to get the child vaccinated with the MCV, and the second dose at 16 months of age. Otherwise, we have seen that the generally dropout comes at the second dose, that is given at 10 weeks, and after that no vaccine is administered to the child. And the last thing, that is the resistance or refusal or myths about vaccination. We are trying our best with the field level workers, with the government counterparts, to engage the community, to engage religious leaders, so that people get convinced and they don't have any questions or myths remaining about the vaccination. But still, we are not successful 100% in this strategy after even involving the religious leaders. We held meetings at the district level, we held meetings at the block level, but still, in this strategy, we are not successful. That is why I have mentioned also that 90% of the cases were in single community only. And that is the most challenging community in my district, because they doesn't understand about the advantages of vaccination. That is why the known pockets are still present. They such pockets where outbreaks have occurred, we have tried to cover most of the children, but still a large number of children are still unvaccinated in these areas. And if we are not able to vaccinate them, then in another 3 to 4 years, when a cohort will accumulate, then we will have another outbreak.
Thank you, Dr. Isha Goyal. We're at the 30-minute mark, which means we do have to make a decision at this stage before we go to Orin Levine, who had questions about your story, your experience. And I need to ask you to go to your keyboards. In principle, we limit Insights Live because we respect your time. We know time is the most precious resource. If you'd like to hear Orin Levine's answers and comments and reflections after having listened to Dr. Isha Goyal's situation and experience, please type yes into the chat window. If you're on YouTube, Facebook, LinkedIn, wherever you are, go ahead and type yes there. If you have no time and you feel this is good enough and you want to stop here, just go ahead and type no. Right now, only as fundo gratitude. And if there aren't enough yeses, then we will have to stop this session. We want to make sure that if we are learning together, everyone actually wants and chooses and opts in to be here. Okay, Boma Tobo, Kingsley, Ninyere, Ravish, Ram, Jeffrey, Mutuali, Nana, Anozie. All right, anyone else would like this to continue? Jenny Sequera, let's see if on YouTube and others. Okay, I see Faisa Rabani has shared an entire story as well as photos that she shared with TGLF. We'll come back to that. Okay, Orin, it looks like we are going to come to you. Right, and here we have John Paul, just one example of folks on social media who are watching, who are following along. Orin, you heard, again, with a lot of detail, but it's just a sliver of obviously the experience of daily work, the commitment over a significant period of time to work with and to serve the health of communities. What are your thoughts after listening to Dr. Isha Goyal? What would you like to say to her, comment, reflect, or ask further questions?
Yeah, Isha, thank you so much for all you're doing and also for sharing it. I thought your descriptions were so thoughtful of the ways that you listened to people in the community and then started to kind of design the solutions, fill the gaps where needed. I was struck by the idea of anticipating fever as a problem because of the feedback you got, and then handing out paracetamol so that parents would be able to manage that and minimize the kind of negative consequences, which, as you described, are typically consequences that women have to take the responsibility for, kind of disproportionately to men. I also was impressed by the way that you were thinking about the engagement of religious leaders as one of the ways to try and kind of shape perceptions around that. I was wondering, when you said that basically every 3 to 4 years a outbreak will occur as kind of under immunized kids build up. Do you have a schedule now, a calendar, where every 3 to 4 years before an outbreak starts, you start to anticipate that and try something a little bit different to raise coverage? Or is it usually in response to surveillance that says an outbreak has occurred?
Yeah, we have the monthly reports of the immunization, by which we are able to identify the number of zero dose children who haven't received the first dose of pentavalent vaccine out of the target. So by that, we anticipate some of the areas, and as a part of surveillance medical officer, it's in our TORs that we do monitoring of the whole of the district randomly. We select areas and we do house to house survey there to find the vaccination status of the children, by which we came to know that which are our poor areas of vaccination coverage, and we always try to improve their vaccination coverage by the best solution possible. So at right now, I also have the areas with me which are still having the poor vaccination coverage, and throughout the year we are working on that. And yeah, surveillance is also part, during for which we have a networks of the local doctors, private practitioners, and the government staff also, by which we come to know as soon as the outbreak occurs, so that public health response can be implemented timely.
Thank you.
Thank you very much indeed to both of you. Now, we are at the 40-minute mark. I'd like to ask Orin if he's able to stay with us for one more story, to discuss one more case and to hear from one more Teach to Reach contributor before we go.
That would be great. I love all the learning that's going on.
All right, wonderful. Then in that case, we'll go to Hamida Mohamed Yaldu. So let me... and turn to our dear Charlotte, who's going to take us through this case now.
Thanks again, Reda. And Hamida, we are glad you're able to join us today. And in your story, you shared that you have so much concern for children, and that has led you to want to pay attention to sensitization on immunization through health education, starting from antenatal care sessions, and also making calls and sending reminders to parents on their children's or their word's next vaccination appointment. So based on what you shared, Orin had this question for you. How can making calls and sending reminders support parents in ensuring vaccination? And are there other forms of support that parents need? So I'm inviting you, Amida, to unmute yourself. Please go ahead and unmute and start by introducing yourself.
Good evening, everyone. I'm Hamida Mohamed Yaldu from FCT Primary Health Care as an immunization officer. Thank you, Reda and Charlotte, for considering my contribution. Well, by using a card, initially we were using a card tracker in our facility to be able to remind our mothers or caregivers for their children due immunization. So our observation is that whenever we call them, it gives them a feeling that they belong to how will I put it? They belong to somewhere that their children have been cared for, and it makes them to feel that the vaccination that they are taking their children is very, very important, which make them that even if they couldn't make it in the facility that they have given their children a first dose, they will try as much as possible and go to a nearby facility, because it gives us more room to educate them, to enlighten them about the immunization. And in terms of support, I don't think there is any need of support as such, because most of them, if they couldn't even make it to the facility, at least we always advise them to go to a nearby facility where they can be giving their children their vaccinations.
Okay, thank you, Hamida. Before turning towards Orin, I just have a quick question for you. Do you organize outreach sessions in your facility that is going out to the community to administer vaccines?
No, though before we do that, but because of the geographical and this thing in the area, it would be the area that we do go for immunization, it was taken away by us. But if not, we were going for immunization. That is like 7 to 9 years back. But now we don't go for outreach.
All right.
Okay.
Thank you. So, Charlotte, there's a question from Becky Tagbo. So let's just bring her. I'm just asking Becky to unmute. Becky, wonderful to looking forward to hearing from you. What is your question for Hamida Mohamed Yaldu?
Yeah, can you hear me?
Loud and clear.
Yes, I can hear you, ma'am.
Oh, thank you. Thank you for that wonderful experience you shared. I'm just wondering how you sustain the airtime for making these calls. Is it the government that pays, or is it the health workers? Thank you.
Initially, we were given support of some funds to be calling, but to be truth and sincere, when it stopped, we continue with our own funds, but later on we feel that we can't continue, so we now stopped.
Okay, thank you, Becky, and Hamida for that answer. Let's back to Charlotte and I believe Orin.
Yes, definitely, Reda. I'll turn to Orin. Orin, just asking maybe what motivated you to select this experience, and any comments, thoughts, or further questions for Hamida?
Yeah, thanks so much for this, Charlotte, and Hamida. Thanks for everything you're doing for children there, and then for sharing your experience, which I'm sure resonates with a lot of the people in Teach to Reach. I think one of the things that drew me to this was the way, Hamida, that you described kind of, there are multiple challenges in terms of parents getting their kids vaccinated. One of them you illustrated was if there's no vaccine available and they take their time and potentially their money for transport to go to the clinic, but there's not vaccine there, then they become reluctant to go again. If you talked about myths, you talked about some of the wishes that you had, and one of the wishes you had was the opportunity to go around a community to share knowledge with them about immunization, and that was actually making me think about the same kind of question that Charlotte had around outreach. So I wonder, do you think that going around the community and doing immunization outreach would help in order to raise immunization coverage in the communities that you work in?
Yes, sir. It does.
Mm-hmm.
Like recently, I have just retired last month. But a month to my retirement, I was informed that there is a community that the population is so high there. So the people that used to go there, not for outreach, but for SIA, that is supplementary immunization activities, they now said they feel that maybe that some of the children don't take their immunizations regularly. So I'm trying to see that now that I have retired, I have a free time. I want to make it. I want to find a time and go and investigate on that environment and see how can I have to be giving them immunization as an outreach. Though I'm not sure that they don't get their immunizations, but I want to go there and be sure that if they don't get, I will just have a time and be giving them the immunization as an outreach.
Wonderful. Thank you very much indeed, Orin Levine and Hamida Mohamed Yaldu, Aisha Goyal, and Rosemary Adejo for these beginning to explore really 3 sets of experiences. We're now at the 58-minute mark, so 43 minutes in. We've gone way over time, but upon request from you, from those of you who are participating, contributing in the Zoom studio as well as online. In the Zoom studio with us are Teach to Reach 9 contributors. I'd like to make one last call before we close for if you'd like to make a comment, ask a question. Oren's been asking the questions. If you'd like to ask him a question, please raise your hand. We'll go to you and then we'll close maybe 1 or 2 people if anyone has is ready to step up and raise their hand in our studio so we can acknowledge you and unmute your microphone. All right, Charles Chaskta is up. Charles, do introduce yourself. Tell us who you are and where you're connecting from, and then what is your question or comment before we close.
All right. Thank you. Good evening. I'm Charles Chaskta from Nigeria. My question is just like this. I'm trying to understand what's the mechanism of tracking the client refer from the facilities, maybe by voluntary community mobilizers or maybe by a practice medicine store. Can we know whether if any of our colleagues online can be able to tell us if there's any mechanism that has been drawn to be able to track the client, whether they brought their children for routine immunization or not? So this is just the question. Thank you and over.
All right, maybe a quick answer from Hamida, if you're able to answer that very quickly, as I believe the question was addressed specifically to you. And Hamida, I hope you are still here. All right, I suggest, so this is Teach to Reach, the continuous learning process. Thank you, Charles, for that question. I'm going to quickly give you an update, maybe a few tips on how to follow up, how to continue learning beyond this Insights Live session. I want to thank, of course, profusely Orin Levine. We're hoping to get some of the other guides on the side into a similar kind of dialogue. Let us know if you like this, if this is useful to you in some way. We'll be asking that question, of course, to Orin. What you're seeing here is our YouTube channel, so I encourage you, if you are not familiar yet with the Geneva Learning Foundation's channel, please go check it out. You can subscribe and make sure you click on the little bell so that you receive the notifications when there is something new. Teach to Reach 10. I'm very pleased to be making this announcement. I do have a technical glitch that's going to take me a couple, maybe 1 or 2 seconds to actually fix. If you'll indulge me, here. So you can see Teach to Reach 10. The theme will be on the front line of climate change and health. Don't worry if you're an immunization staff. Immunization will remain very much at the core of Teach to Reach in June of 2024. We'll have many different sessions for the Movement for Immunization Agenda 2030. Again, this is peer learning at scale. Everyone knows that learning from experience is one of the best ways we have available to actually learn to make a difference, learn to achieve impact. Teach to Reach 10 is peer learning at scale with people from over 80 countries participating. A big focus on climate change and health, as well as a follow-up to the Manifesto for Global Health that was developed by over 1,300 health professionals from all over the world. We'll be inviting, of course, women who deliver vaccines, a collective of women who work in immunization, to Teach to Reach 10. Everything we do will go into the knowledge. Everything we learn together will go to the Knowledge to Action Hub, so that even if you're not at Teach to Reach 10, you can still benefit from it. Now, if you haven't yet looked at the shared experiences, you can go to a repository called Zenodo, and here you'll find all the data sets from Teach to Reach, all of these compendia of experiences that you've shared over the years, and we honor, of course, our contributors. That is it for this edition of Insights Live. Thank you for having been with us. Wonderful. I'd like to thank all of the Teach to Reach contributors, Orin Levine. We also saw Laura Schimp and a few other of the guides on the sides, François Gasse, and many of you who are here in the room, in the Zoom studio with us and following online. Let me just show what is happening here in the chat. As Israel Solomon, Jenny Sequera, Boma Otobo, Jeffrey Mutali say thanks and bye. Dr. Isha Goyal, Israel Solomon, Hamida Mohammed Yeldu. All right, and this is actually the first live stream of 2024 for the Geneva Learning Foundation. Thank you very much indeed. One final chance to get some messages in there, and we look forward. Let us know if and how this helps you so we can continue to improve and work with you to offer more dynamic peer learning events at scale. It's simply in the globalized world, it's simply not enough to know what you know because you work there. We need to hear and learn from each other. Comment from Charles Adeyemo Sunday. Charles, well done for good organization. And I did want to share this story. Let me see if I can shift back here. Faiza, for those of you who stayed to the end of this session, Faiza shared yesterday so she used the chat in YouTube to share a case. I conducted a special, she's in Pakistan, Dr. Faiza Rabbani, a special mobile camp at a factory area. The mobile team members shared their challenges in conduction of field camps. She sent us pictures. Most of the pregnant women workers appreciated the awareness session on the importance of vaccination. There's a great opportunity as the daycare center for children was seen for the first time. Isha depicted the situation similar to that in Pakistan. Yes. Lucius Darby Donsa from Malawi. All right. Thank you once again. We have to stop at some point. We look forward to seeing you soon for the next Teach to Reach in June 2024. Thank you and goodbye. All right, Rob, you will be looking at the email. I haven't seen anything from you. Definitely be looking. All right, take care. And I gotta ask Charlotte, have you missed this?
Definitely, Reda.
Right.
Definitely, it's always a pleasure to reconnect and especially listen to the voices of you that are making a difference in immunization. Because if we are having coverages change, if we are having children immunized, outbreaks that are we take control of, it's thanks to the work that you are doing, connecting with communities, reaching the children, and ensuring that they get the much needed vaccines. And looking forward to more experiences in the future, especially as there is a special scoop from Cameroon. Cameroon has just introduced the malaria vaccine into routine immunization. So the first country to introduce the malaria vaccine in routine immunization. So probably we'll be looking forward to hearing experiences around that at Teach to Reach.
Indeed. Thank you, Charlotte. Take care, everyone. Bye-bye.
Bye.